Good afternoon, everyone. With the blessings of His Holiness Swamiji, I welcome everyone to today's webinar on extracoronal full coverage restorations for primary dentition. I'm Dr. Insia Contractor, and I'm honored to be the host for today. As we all know, management of severely decayed primary teeth is one of the greatest challenges for us pediatric dentists. Retention of the conventional filling materials is generally very poor. Full coverage restorations have always been recommended for multi-surface caries lesions or pulpily involved teeth. This increases the long-term stability of the restoration. Today's webinar will enlighten you about the newer updates on extracoronal full coverage restorations and also compare the clinical performance of aesthetic and non-tooth colored full coverage crowns for primary teeth, their durability and stability. We have with us today the organizing chairperson, Dr. Nandlal B. He's currently the head of the Department of Pediatric and Preventive Dentistry at JSS Dental College and Hospital, Mysuru, and has also been the former dean of this institute. He has been the backbone behind organizing this webinar today. I welcome you, sir, and would request you to kindly address the gathering.
Thank you, Anshia. At the outset, on behalf of the JSS Academy of Higher Education and Research and JSS Dental College, we wish all the delegates and the participants a warm welcome into the afternoon. I will take the privilege to welcome our speaker, resource faculty, Dr. Tarun Walia, who has taken out time to deliver this lecture today to all the participants here. With his wide experience, I welcome you, Dr. Tarun Walia. And also, it's my wish to share the greetings from the Vice Chancellor and the Registrar of the University who have actually conveyed this virtual greetings. Otherwise, they would have come over and welcome. As continuing dental education is a part and parcel of any institution, so we normally have this programs on regularly, and now being virtual, and in fact, we have increased much more than the regular time. So with this, we look forward, Dr. Tarun, your interaction. Though you have been giving a lot of lectures across the world, but this time with JSS, and I'm sure this is going to be a great beginning, and you will definitely find more things to work together and collaborate together as we have been discussing for the years to go. I welcome you again, and thank you for accepting this invitation and coming over the virtual platform at this on a I think it's a off day for you, so you agree to it. I thank you once again. And with this, I can go the platform back to our moderator.
Thank you, sir. Our speaker for today is Dr. Tarun Walia. Dr. Tarun Walia has received his postgraduate degree in Pediatric Dentistry from the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh, India in 1997. After residency in the same institute for 3 years, he moved to Dubai in 2001. He acquired membership in Pediatric Dentistry from Royal College of Surgeons of England in 2003. Presently, he works as the Program Director and Associate Professor in the Unit of Pediatric Dentistry in the Department of Clinical Sciences, College of Dentistry in Ajman University, Ajman. He is a founder member of the Emirates Pediatric Dental Club and has keen interest in areas of aesthetics in primary dentition and early childhood caries. He has made significant contributions to the field of pediatric dentistry, both in India and in the United Arab Emirates. He has several significant contributions to the field of pediatric dentistry, both in India and UAE. He has several research publications in peer-reviewed journals and is a reviewer in several international dental journals. He's a regular guest speaker in the national and international dental conferences. He serves as a member of the membership committee of the International Association of Pediatric Dentistry. He is also a member of good standing in International Association of Pediatric Dentistry and International Association of Dental Traumatology. Needless to say, he is a man filled with wisdom, and we are honored to have you with us today. I welcome you, sir.
Thank you, Dr. Inchia, for your kind introduction. Good day to everyone from sunny and hot and humid Dubai. Dr. Can I share my screen now? Is it okay?
Yes, sir.
Okay. First of all, I take this opportunity to convey my heartfelt gratitude to all the patrons at JSS Academy of Higher Education and Research, Mysuru, and particular my thanks go to Dr. Nandlal. He is my senior at my alma mater at PGI MER, and we have a close contact. And in fact, the entire department of yours, Professor Nandlal, of pediatric dentistry and preventive dentistry, I really appreciate your efforts in organizing this webinar and giving me an opportunity to share, my interest of my field of interest, that is, aesthetics in pediatric dentistry. Before I start, I would like to, share one picture which I took in 2003. In fact, it is on the internet as well. I still remember I moved to UAE in 2000 September, and I was staying with my family in a hotel, and I took this picture, from the hotel balcony. And coincidentally, this picture, I will like to tell you this picture, what this picture is, what it came out later. And if I showed you the present, day picture of this area, this is the area right now. I am sure some of you already has visited this city of my residence, that is Dubai. And you can imagine in last 2 decades, what all changes has occurred. So similarly, a lot of changes has occurred in the field of pediatric dentistry also. And some of you who have been my contemporaries, my seniors, and I can see some of my teachers are also there today in this presentation. They will agree with me that when, we in our time, we always used to have this, undergraduate training, class 2 for silver amalgam restoration. And in fact, this is one of our exam exercise. And if they will see the contact area, they will see all the line angles and, external outline, internal outline forms. So, but over the period of time, now I'm sure in India also now, the silver amalgam is almost obsolete and everyone is doing tooth color restorations. And similarly, for the extracoronal restorations, the stainless steel crowns are definitely in demand as of now. But because there is expectation from the parents, our patients themselves, we have to give them an alternative. That's how your tooth color aesthetic full coverage restorations are also coming now in the market. So whenever demand is there, you have to fulfill that demand, and that's exactly what change has happened. Excuse me. Now, what are my learning objectives for this presentation? We will understand what kind of difficulties we face in restoring the primary teeth, both interior as well as posterior, to identify where you should go for facial restorations and where you need to, or you prefer for a long-term success of full coverage crowns. Then you also will understand and recognize the need for the full coverage restorations for the primary teeth. And I will be sharing you some long-term, cases where I have, put the crowns, full coverage crowns for interior and posterior. As I told you, this is the area of my, interest, and I have done in fact, just to take you a little bit back, my interest started in 2011 when I attended the IAPD, International Association of Pediatric Dentistry conference in Athens, in Greece. And there, the first time I saw, a zirconia crown, I was amazed because I had an interest already. In fact, I will say that my interest was created in aesthetics in primary dentition when I was, postgraduate students at my alma mater at Chandigarh. And from there, I was always, trying to have a custom-made crowns for sometimes, fillings for a tooth color restoration. But when I saw the zirconia crown, I was amazed with the prefabricated zirconia crown from the primary teeth. And I started, when I went back to Dubai, I started, start thinking how we can, have a collaboration and kind of a research with the manufacturing companies to see whether, this is a practical and available solution for the primary dentition. And so that's how, my journey and story starts with the full coverage crowns, especially for the aesthetics crowns in primary dentition. And the final learning objective is to explain the significance of full coverage crowns, that is extracoronal restorations, in regard to our profession, that is pediatric dentistry. So, before I start with my lecture, I always, tell my students also that a small lesion in a primary teeth, in a primary dentition, because of its thin enamel and dentine, less mineralized tissues, or close proximity to pulp, it behaves like a large lesion of a permanent dentition. And this small difference is of paramount importance of success or a failure of a restoration in a primary dentition. Although the restorations in primary teeth are technically temporary in nature, right? We all understand that these teeth are going to exfoliate, but still they are going to, serve for a longer period of time, sometimes for 5, 6, 7 years. So the durability, the retention, the aesthetics, we can't ignore that. We can't underestimate that, this is a temporary filling or temporary teeth for that matter. And let's, sometimes I feel, really, I'm sure it is same with you also in India now. Sometimes you see a children with the grossly destructive dentition, and then when you ask the parents why you didn't restore it before, some of them will say that we went to a dentist in the town or a city or a university, and they told us, no, it is a temporary teeth, it will fall, no need to do anything on that. I really get amazed, as our professional colleagues, how they can say that. I always tell I wanted to reply to those dentists that if you have a caries in your teeth, can you keep it? You will not restore it for 3 or 4 years or 5 years. Okay, we understand the permanent teeth is going to stay for a long time. But if the caries is there for, say, allow it for 3 years and then you restore it later, will they do that? No, they won't do that, right? So what I'm trying to explain is that the primary teeth restoration, the primary teeth, restorative management has got its own importance, and it cannot be underestimated. We, as a dental professionals, owe a responsibility to our child patients to give them the best dental treatment, whether it's preventive or whether it's the restorative dental treatment, because it is going to shape their dental future. So the objectives of the primary teeth, restoration of primary teeth, are to repair or limit the damage to the dental caries so that it doesn't progress, because as I mentioned in my opening slide, that because of the thin enamel dentine, less mineralized tissues, there are high chances that the caries can progress to pulp in a very quick period of time as compared to the permanent dentition. And of course, to preserve the remaining pulp and tooth structure, it will also provide adequate function and restored aesthetics, especially when it concerns the anterior teeth. Of course, finally, it should always, the restoration which you are selecting should be, it should give a patient of ours, the child patient of ours, to give full opportunity to maintain a good oral hygiene. I understand that sometimes we, in spite of our best, intentions and our highest quality of dental treatment which we provide to our dear child patients, still the maintenance of the oral hygiene is not that good in some categories of the patients. That's okay, but as a dental professional, we should also keep in mind when we select any restoration, whether that restoration is going to survive over a period of time, or if the child is not able to brush properly and the plaque is there for some period of time, whether the restoration is going to fail or it will be retentive. All these factors should always keep in mind when you select any kind of a restoration for the primary teeth. Excuse me. And you all will agree with me that restoration of primary teeth is challenging, right? Sometimes the management of children is quite challenging. This is because the teeth are smaller in size as compared to the permanent teeth. They have a relatively very thin enamel, which gives us a lower surface area for bonding. Okay, so if you are going to have a bonded restorations, intercorneal restorations, or fillings for that matter, if you have a very less surface area for bonding, definitely this restoration success rate is guarded. Then enamel composition, calcium phosphate, the ratio of calcium phosphate in the enamel of a primary teeth as compared to the permanent tooth enamel is completely different, and that's the reason these teeth are always at high risk for having dental caries. And the last two issues is one. The issue is related to the child behavior, because child cooperation is always an issue or always a problem area for us as a dentist. Okay, and time and the cost factor. Yes, these are all, because cost factor means, because if we are going to put a tooth color restoration, I'm sure you must have, given option to your patients or parents about the tooth color, say full coronal restorations, the crowns, and then they say, though it's very expensive, the tooth is going to fall out for some time. Why you have to do all these costly factors, costly treatment? But what I feel that these are all okay. These are the points which we all know and we agree. But for me, these two, the last 2 points, that is professional approach of us as a dentist, or for us as a pediatric dentist, is very important. If we ourselves think that no, it is important for the child now. For now, all the days we are always seeing in all the journals, if you take out the latest issues for last, say, 7-8 years, you will see 1 or 2 articles or manuscript on oral health, related quality of life, correct? And now, a lot of governments are giving impetus and focuses on the quality of life for children as well. And oral health related quality of life also is very important. So this is important factor which we have to keep in mind. So we as a professionals, sometimes sorry to say that we fail ourselves. And secondly, commercial sport. I mean, in fact, now commercial sport, I should actually delete this line in my slide. It is improving. But when we were, students, or say 10 years before, there was hardly any dedicated restorations for that matter, extracoronal or intercoronal restorations, which were only dedicated for the primary teeth. We were using all the restorations which were meant to be used for permanent teeth, whether it is composites, whether it's compound, whether it was glass ionomers, or for that matter, even the full coverage crowns. But now, as I discussed with you earlier, because of the demand from the parents, because of the expectations of the child, patient, or for that matter, parents or societal expectations, definitely commercial sports is coming now. We are having, dedicated restorative materials, whether it's, composites or a high viscosity glass ionomers, or you can say full coverage, tooth color restorations, it is coming, and commercial sport is there. The situation is improving, and I'm glad to see this. Now, any restoration which you are planning to do for a primary caries teeth should be durable. It should able to, resist the forces from the mastication. It should survive, not like, you have put it, sometimes the wear strength is there, it is fracture, secondary caries is there, or if you put a crown or a aesthetic crown and your, some cracks or some meshwork of the composite is broken. So always, whenever you are planning to do a restoration, whether it's a filling or a crown, always think which is going to survive in that particular mouth. It's not the tooth. Of course, we are treating a tooth, but the tooth is in the mouth. So a lot of factors are playing in that particular mouth, which particular kind of a filling might not survive. In fact, I always used to say, inform my students also that we, after 25 years of doing pediatric dentistry, and including my training period of, say, another 7 or 8 years, sometimes even I feel that, okay, we as a dentist get used to a particular kind of a material. We are using, say, glass ionomer or a resin modified glass ionomer or a composite, whatever. So we try to, we tend to use that kind of material for all different patients. If you have 5 patients in a day in your practice or in your training or a university setup for a filling, and you cross your heart, you will see that all 5 normally we are doing the same kind of filling material which we are using it for one patient, but which is not true. Sometimes the caries rate is so high, the child is a high caries risk status is there, so patient is not maintaining oral hygiene properly. There are big class 2 lesion in compared to a moderate size of a class 2 lesion. Still we go for the same kind of a material, aren't we? So always think in the full mouth as a whole, and then even if you're treating a small filling also, keep in mind whether this filling is going to survive for a long period of time. In fact, when students come to our college for training and they do a very good class 2 with a good carving or a good finishing, good contact points, everything is nice, and they show me with excitement. This I always say that's a good work, but I always tell them, please follow this patient, call this patient and see how long your filling is going to stay or durable. Whether what you have done, if you have done such a good filling and doesn't survive till the time of exfoliation, I can tell you have not done any good for the child or for that matter parents. So always think whether whatever decision you take, it is going to last for till the tooth lasts. This is the ideal. Okay. So second point, when you are selecting any kind of a treatment, whether it is say filling or a crown, always think whether the filling which you did is going to be retentive. It's going to stay, again I say, stay till the tooth exfoliates. Okay, not like you have done a filling today and after 1 year you will see that the filling is fractured and secondary caries came and the tooth requires the pulpal treatment, and then of course need a crown. If you think that it is not worth, go for a more aggressive option, that is a full coverage crown, rather than doing a filling. Of course, caries prevention, we all know that any treatment or any restoration which we put in the child's mouth, we should make sure that that should aid in prevention of the caries rather than, it should aid. Okay. So if you think that, of course, I mean, this case, if you do a filling and filling is not going to survive, or it is going to cause a secondary caries later, try to think about the any other kind of restorative material which will, is going to survive at least longer period of time. So it should be caries preventive. Okay, tissue friendly. This is also very important. I always emphasize that if you are restoring any primary caries teeth, please keep in mind that the restorative material or a technique which you use should aid. Our patients, right? Child patients, you can't expect them to maintain an excellent good oral hygiene. Of course, this is an ideal scenario, it should be there, but in case it cannot, and these are all, a moderate or a high risk caries children, if the younger you see the child with so much of caries, right? So always select a material which will be, you can say little bit of generous, or maybe, we should not be plaque retentive. It should not cause, retention of plaque or deposits and causing a massive gingivitis like this. Of course, we can say that these are the restorations are durable, but whether it is tissue friendly, whether it's biocompatible, always keep in mind. This is zirconia crown, and we're going to discuss in detail about the difference of, in between the zirconia crowns in molars as well as stainless steel crown also. Look at these two pictures is of the same mouth. It's the same mouth. Look at one quadrant, we did a split mouth study, it is published also. And look at this, how much the gingivitis is there on the palatal or the lingual surface, and look at the zirconia crown. Okay, because of so much of smooth surface, the plaque retention is minimal here. And finally, any restoration you do should be, as far as possible, aesthetics should be not compromised. Okay. Try, because see, all these amalgam restorations, of course, there's amalgam mercury toxicity is there. But if you ask me, more than a mercury toxicity, the aesthetics is the reason. Okay, aesthetics is the reason where the amalgam restorations have ceased, and we not used anymore in any majority of the world, And full coverage crown, yes, stainless steel crowns. I am not denying that fact. It is established. This is so last, say, 4 or 5 decades. The crowns are from 1969. If I'm not wrong, Humphrey, I forget the name of the, the person who started this one. The crowns, the stainless steel crowns for primary teeth. This is no doubt about that. It has got a very good durability, retention. Cosmetics, yes, definitely is a question mark here. But of course, with now Hall techniques coming, this is a very good option. So that's I'm telling you that, like for example, change. Before we were always, training our students to how to do a good restoration, how to do a restoration which will be long lasting. Now we are teaching them, if the child is not cooperative, you think that you cannot do the filling, directly go to the Hall technique, right? Put the full coverage crowns. So this definitely, there are some indications which the stainless steel crowns are there, which cannot be replaced. Okay, but always keep in mind psychosocial impacts of caries. If you go to the literature evidence, there are so many studies, numerous studies you will find in literature where they have, the authors have tried to study the expectations of the parental expectations or parental attitude, or what kind of restorative materials can be used in their children's mouth. If you take, if I give you my personal experience, I have a private practice also in Dubai. And so many times, when you are doing a pulpotomy or a pulpectomy and you tell the parents that now we are going to put a stainless steel crown. Some of them, they say, we don't want this crown. They say that we don't want this crown. This is too much dark in color. We cannot. You can put filling. And when I say that no, filling will not survive for a long period of time, it can come out, blah, blah, blah. And it's better to have a full coverage crown. You say, okay, you put the white crown, which if I give them option of zirconia crown, but the zirconia crown is expensive, and the insurances I'm talking about Dubai. It's I mean, as a country here, they don't approve. I mean, give insurance is not covering the zirconia crowns for prime molars as of now. Interiors they still cover. So they say that it's not covered. Either they will pay from pocket if they can afford it, or if they can't afford the zirconia crowns, they will say put the filling. In spite of telling them that it is not good, in the long run, we don't want. And I'm sure some of you must have already experienced in your clinical practices as well. When you show them the stainless steel crown, they say that we don't want. And I mean, I can assure you something, that as the time will progress, we as a dentist, are already started listening to the parents. They sometimes detect terms with us that, okay, we want this kind of treatment, we want this kind of materials or kind to be used, and to some extent we do listen to them. Of course, we have to explain everything, we have to write and document everything what we have told them, but we do listen to them, right? If you say every time when patients or parents say that we don't want this kind of treatment or this kind of a material or this kind of a crown, you can't say that, okay, we will not do it. In all cases, right? You will lose all your patient that way. Of course, you have to find the middle way and try to, do the treatment. What I'm trying to say is, now more and more pediatric dentists are giving in to the parental demands and expectations. And we have to find a middle way, so that we are on a safer side. In fact, I mean, in a lighter way, I always, I say to my students that now these days the pediatric dentistry is no longer really a real sense of pediatric dentistry anymore. It has become a parental dentistry. Parental dentistry means sometimes you have to manage the parents' expectations. You have to manage the parent, demands that, okay, we want like this. We don't want the child to be crying. We don't want this. I mean, so it is not easy. And when you are doing a high, quality dental treatment, and if you're charging quite a good amount of, money for a primary dentition, better you should be, excellent in your treatment planning and your decisions. So coming to the restoration for the primary teeth, let me see how much time we are on. Okay. So now coming to the primary teeth restorations, we have basically two kinds, that is intracoronal and full coronal restorations. Anatomical, features of primary teeth always dictates, always tells you, always, helps you in deciding which kind of, restoration you should plan for your long-term success for your restorations. Intracoronal restorations, basically these are fillings. They are indicated when you have a limited loss of tooth structure. I always say, if some students or postgraduate students are listening to me today in this presentation, please select and only go for a filling when you have a sound, strong walls around your filling structure. And younger the patient, the more true this is. Okay, because the filling is going to stay for a long period of time in the mouth, right? So when you have a limp, because see, if you are doing of course you are doing a tooth color restoration, which is dependent on bonding to the enamel and dentine. So if you have less tooth structure, your enamel and dentine bonding will be compromised, and you are going to have a failure in your restoration. When you have, for example, a class 3, class 3. If you have sound enamel all around, yes, you can go a class 5 for that matter. If you have a sound enamel all around and you think that you have got a good cooperation and isolation, of course, is good, you can definitely go for a filling. No problem with that. But the more bigger the lesion is, the more chances the failure going to happen. Okay, because the filling, see, these kind of cavities which you see in a very young age, unfortunately, right? Definitely, I will, this kind of cavity, if the lesion comes to me, I will always go for a filling, but especially for the interiors I'm talking here. But the younger the child is, then again the cooperation comes. Of course, the sedation, and I'm not going to that direction of sedation or from that matter pharmacological management of child behavior. But again, you have to keep in mind all these factors, when you take a decision. But per se, if you have a good amount of enamel for optimal bonding of your restorative material, go for fillings. Okay. And filling should be, of course, as I told you, preferred in mild to moderate caries, which requires a minimal tooth preparation and preserve good amount of enamel, and you can do, and you can ensure that the retention of your restorative material is there. But again, there are limitations with the fillings. For all these tooth colored materials, of course, from say from at the higher level, it's a composite, then go to resin modified and glass ionomers, are technique sensitive. The moisture and hemorrhagic control is of paramount importance. It's difficult to control in young children. Of course, rubber dam is a must if wherever possible. Sometimes rubber dam you cannot apply. You know that, especially if you're doing on a chair side, in a dental operatory. So I always say, tick is it should be ticked. T is time, that you should be fast. The more, if you select a technique or a restorative material that needs a lot of time to do the restoration in a very young child, the cooperation is going to be affected. Isolation. If you're going to use a restorative material which needs a proper bonding, isolation is a must. And of course, lastly is the cooperation with child. Okay, so cooperation is not there. Whatever you do a filling, it is going to fail. That's the reason how the whole technique, the rationale of the whole technique is that, right? So coming to being in academics, I always go for literature and evidence. In 2018, a very nice research paper came from Brazil, and systematic review on survival and reason for failures. I'll just come directly to the results. And AFR is annual failure rate of restorations. Of this many restoration, 37% was due to secondary caries. So just imagine if you're doing a filling, you can always keep in mind that at least if you're doing 10 fillings out, almost 4 fillings can have a chance of secondary caries if you are all these previous factors which I just enumerated is not kept in mind. Even you are doing, this was done in quite a good, it's a study with a lot of articles, and it has been taken and studied properly. Another study in Cork in Ireland. This was done by students, okay, and undergraduate teaching program. This did the study of a primary teeth restored by the fillings in children. And the result was that restoration that involved more than one surface is almost twice the failure rate of single surface. Single surface, definitely the success rate is very high, okay? But the moment you go to a multi-surface caries lesion, start thinking about full coverage. Whether, of course, you have to look into the price factor, the time factor, the parental expectation, the cooperation, the time the tooth is going to stay in the mouth. All these things have to be kept in mind. But underlying statement is the moment you have more than one surface which is involved in a primary teeth, the chances of failure of filling becomes double almost. So coming to the extracoronal restorations. So actually, my presentation is an extracoronal restoration, and I have taken at least almost 30 minutes, for on describing about the filling, which is very important to differentiate, to understand what are the advantages, what are the indications of filling, and what all factors you should keep in mind when selecting for a particular kind of treatment. So extracoronal restorations, of course, it will cover the external surface of the prepared tooth. And because of that, it obtains retention and resistance to the displacement. The indication is multi-surface caries. When you have in interiors, when interior teeth are involved, the movement indication is incisal edge. The moment incisal edge is involved, trust me, filling will never stay. Go for crown, whether it's a strip crown, whether it is a preveneal crown, whether it is a zirconia crown, that is irrespective. That can be, we will discuss later. But most important is when the interior primary teeth are concerned, the moment incisal edge is involved, whether it's 2 surface, 3 surface, whatever, you do full extracoronal crowns. That's what exactly I was mentioning here. Okay. Now look at this. Fillings was done. and what has resulted. Of course, it is lucky the child, maybe the protective factors came into play in this mouth, and it has not resulted into the pulp involvement. The secondary, I mean, it is arrested caries, but still the restoration was not attentive and durable. So of course, in high risk caries children, always go for full coverage, because if you're going to put a filling and so much of caries is already there, especially class 2, small class 1s are fine, but all these, for example, in this picture you are seeing, I'm sure your teachers or students are sitting here, or the practicing, pediatric dentists, always go for a full coverage crowns here. Yeah, extensive cervical decalcifications. I'm sure sometimes because of nursing bottle caries, you see, this kind of caries lesions, okay, and it's like a complete neck of the tooth is involved. If you see the palatal surface also has a caries, go for a full coverage crown. Even if you see here, this picture, the third one, now it's very minor initial decalcification. We say, oh, we can, if you are going for a filling, I'm talking about, okay, or you can, I mean, there are the, of course, the minimal intervention dentistry is there. I'm talking about the restorative dentistry here now. I'm not talking about that aspects, okay. But if you have planned to do a filling, okay, if you plan to do a restoration, always think whether your filling is going to, because what are you going to do here? You're just simply taking a inverted cone burr and then making a class 5 and trying to do whatever retentive grooves you can give, and you cover it. But the child is very young. Child is already maybe on the bottle feeding. So you keep in mind whether it is going to survive for a period of longer time or not. Okay, and of course the behavioral issues will be there if you're doing the on the chair side in a young child. So always keep in mind all these factors. And all this you all know. I don't have to describe anything on this because of the extensive carious lesions in a pulp involved teeth, and of course as a pulpal procedure itself, we have to cut a lot of the structure, so we need to put a crown. Okay, and general anesthesia. If you're performing a comprehensive or complete oral rehabilitation under general anesthesia, always go for a higher option. I always say be on it will benefit you to be on an aggressive side. But what I'm trying to say is that in a general anesthesia, if you are not sure about whether the class 2, I just give you an example. If a class 2 restoration is not going to survive for a period of time, because you are doing majority of the cases in a very young patient, right? The general anesthesia. So go for pulpotomy and put a crown. So if you are not sure about your pulpotomy succeeding or not, go for pulpectomy and put a crown. If you're not sure about your pulpectomy is going to succeed or not, extract it. Trust me, it is always better to be on follow aggressive approach when you're going for general anesthesia. Because if you do a filling in some teeth like this it mentioned, and filling or fractures or restoration fails, and child is young, the child will not give you a second opportunity to sit on the dental chair and you can restore it again. And it is definitely going to be a very difficult position for you to explain in front of the parents. Okay, in 2018 in GOCPD, an article came on survival rates of stainless steel crown versus multi-surface composite restorations by dental students. And they said 1.5% of the stainless steel crown only failed, whereas 21% of more than one surface filling, composite fillings failed and needed a replacement. So take the carry home message is that if you have a bigger caries lesions with having more than one surface involved with the caries, go for full coverage crowns. Okay, so this is summarizing what I discussed. Factors: patient age, behavior, and cooperation. Younger the patient, go for full coverage crown. Behavior and cooperation. If you are not sure that patient is going to cooperate for a class 2 restoration, okay, or for that matter class 3 restoration, go for a full coverage crown. It will always help you. Ability to control the movement of the child. Again, it is related to the first factor. So you have to decide whether you can manage it. Of course, if you are doing in the pharmacological management methods are being employed and you can easily control the movements, then go for the best treatment which is possible, whether it is a filling or a crown. Ease of technique, okay, which is more easy for you as well as the patient, okay, depending upon the cooperation level. Chair time requirements. If you are doing under local or without any pharmacological method, that is sedation with nitrous oxide and analgesia, or for that matter general anesthesia. So always, keep in mind whether you can put a crown on time or properly or not, whether filling will take more time or not, because the more time it takes, the more difficulty for the child to sit, stable, and it will definitely affect your, treatment. Demands of class C cavity preparation always should keep in mind. Interior, younger the child, the smaller will be the lesion. But same time, the behavior cooperation will also be there. So always keep in mind like that. Okay, moisture and hemorrhage control. All you know that if you are not able to control these factors, especially the tooth bonded restorations are definitely going to fail over a period of time, or secondary caries are going to come. Caries risk assessment, the higher the child is at risk for the caries, developing future caries, always go for full coverage crown. And of course, all these factors, dictated by most important thing in this present day world, that is cost. That also has also be, keep into consideration before you decide and propose any treatment to your patient and the parents. So I'm sure all of you are aware of these kind of, crowns. I won't take much time on these. So we have a composite strip crowns, pedo jacket, and polycarbonate crowns were there, basically co-polyester type of a material where, it was before. Now, actually speaking, I have not used it for so many years, especially the pedo jacket and polycarbonate crowns. Composite strip crowns are the universally accepted crowns now. And then second ones are the preformed crowns, which can be cemented with the luting cements. You have a conventional stainless steel crowns. And then you have a open face stainless steel crowns. You cut the facial part of the stainless steel crown for the interiors and do with the composites. Then you have recently introduced fiber reinforced resin crowns are there, and the company name is Figaro. Figaro is the one. Figaro is the one company which is started manufacturing fiberglass reinforced resin crowns. I will discuss about that crowns in a short period of time. And then you have pre-veneered stainless steel crown, and then finally you have a monolithic zirconia crowns. So full coverage crowns. See, I'm not going to discuss in detail about the preparation, about the indication. You all know that, I'm sure. I'm going to discuss with my experience what I have felt, what I encountered, the difficulties and the failures. Okay. So majority of the time, you will see that I will be focusing on the next 20 minutes or so about these factors, what problems we have encountered in these full coverage crowns. And stainless steel crowns I will not be covering, because I will be focusing only on the aesthetic crowns, because stainless steel crowns, and problem, I'm sure you all have been used to it, and problems are minimal, except the aesthetic part. So I'll be focusing more on other type of full coverage crowns. Stiff crowns disadvantages are technique sensitive, requires cooperation from the child. Of course, it's required optimum isolation, moisture control, as I mentioned before, sufficient tooth structure for bonding. I've seen, a lot of social media where, I mean, so many nice composite built-up crowns are shown for the primary teeth, hardly any tooth structure left. Even to be honest, I have to admit that when I was a student, or when I started practicing my early life of my clinical practice, I was doing composite stiff crowns on a badly restricted primary interiors with hardly any tooth enamel for bonding. And trust me, out of that, half of my crowns which I placed came out. It was dislodged. So please don't get tempted to do a stiff crown. Oh, I will take a sport from the sub-gingival level, and this, it will not work, especially when you're doing it the general anesthesia. Okay, in chair time, if the tooth is going to exfoliate in next 1.5 years of time, parental expectation is very high, cost is a factor, they can't afford the full zirconia crown. So definitely you can, but I will not advise that. It's better to do pulpectomy and cover the SS opening, leave it like that. Or if they don't want, you can extract it. Okay, but I will never advise to do a stiff crown on a tooth structure where hardly any enamel or dentine is remaining. Sorry, gingival hemorrhage. can also alter. This is a problem, right? Because you have to insert the strip crown quite, at least 1 millimeter inside the gingival, margins to have the good retention, and the crown margins cannot be supragingival. So again, the bleeding is there. I always seen this is always a problem for whether it is a strip crown or whether it's a zirconia crown, any other crowns for the interior teeth, because all these, when we are going to restore the primary interiors in children, it means that the child is quite young, 3, 4, 5 years. This is the age group, right? By 6 years, you don't do that because tooth is going to be already under exfoliation or it is already loose, right? So child is young, okay, and cooperation, it will be minimum. I'm talking about in a normal, without any, inhalation with the nitrous or for that matter, anesthesia. So, and they are high risk children, right? Of course, they have interior caries for, last maybe 2 or 3 years or a young age. So it means they're high risk for caries. So, and they you must have seen, because of the caries root stumps or caries enamel in the interiors, the plaque accumulation is quite a bit around. The moment you take the burr to reduce the tooth, the bleeding starts from the gingiva. Whatever you do, right? I'm sure you must have, thinking that just we all have experienced this kind of problem. So what I do with my experience, I will share with you also in later slides. I see, okay, today you have decided, patient comes to you that you are going to do a strip crown maybe next week or whatever. Always tell the parents, at least for next 2 days or 3 days, at least brush that area properly. Give chloroxidine gel, do something, make sure that at least the gingival health around these kind of these interior teeth, which you are going to put a composite strip crown on a full coverage crown for that matter, at least the gingival health is at least not excellent, at least optimal. Okay, so that at least when you touch the these margins, they don't bleed immediately, and then you have a problem, right? For doing all these issues will come of isolation or moisture control. So Kupitsky is a good friend of mine. He's the General Secretary of the International Association of Pediatric Dentistry from Israel. And he did a long-term evaluation study, on composite strip crowns. Because it's a composite, the plaque, and the composite restorations are known to be plaque retentive. Yes, you have a very good advantage of with composite strip crowns to have a excellent shade matching, because you have a composites, you can decide the shade which normally it is A1 shade, but still you can do that. But again, composites take stains of you from the food, from the from the plaque also, or from the dietary part. Okay, so over the period of time, I have seen even discoloration is there. Loss of form. So you can see here, sometime the fracture of composite strip crowns occur. The composite buildup occurs, and margin discoloration. I already told you, and they look at the plaque, and that's what I was telling you. So how you can what are the problems which you encounter with the strip crown, and you can solve these problems? If you have a tearing of cellular crown form when you're trimming, sometimes you have done a good reduction of the tooth for the strip crown. You have a strip crown in your hand, you have trimmed it properly, but especially it happens with the 3M. Okay, 3M crowns, fresco is okay, but 3M crowns, the moment if the Caesar is not good, definitely if you put more pressure to cut the strip crown, because the 3M strip crowns, especially the other kids crowns also, E crown, the facial and the lingual part of the strip crown is you can say sometimes is a machine compressed to just to make it a single piece. So the moment you put more pressure to trim the cellular crown according to the tooth structure, it will tear, and then again you have to start over again. Okay, what I do when the patient comes on the today appointment, and I decided that I am going to put a strip crown, I always prefer to plan this kind of this kind of treatment, especially the crowns. And then what I do, I select the size of the crown. Well, normally it's 1 or 2, sometimes 3 also, but at least approximate. So what I do, I always prepare, I trim the cellular crown 2 sizes, at least 1 and 2, and keep it ready. And then because it will save time. If the patient is sitting in the dental chair and then you're cutting the crown and then you're fitting it and then second crown comes, and if it tears, then it takes time. And the child, you're dealing with a very young children. So always, try to prepare the salivary crown to some limit, and then at least minimal modification you can do on the chair side. So splitting of the split crown when sitting it. Yes, this is another problem. Some practitioners says that you can make a small hole with the explorer tip on the strip crown on the incisal edge, so that it creates a little bit of way for the extra composite to come out. But for me, I used to do it, but now I've stopped. It doesn't make a difference. If you have put a good amount, don't overfill the composite or overfill the crown, strip salivary crown. Otherwise, it will definitely split. Okay, and when you are inserting the strip crown on the tooth, just use gentle pressure and rocking motion. Don't immediately try to over push it. Otherwise, it will definitely come out. And I have also seen that if your reduction of the tooth is not enough, if you have just minimally reduced it and you overfill the composite with the strip of the salivary crown and then you push it while seating, it will definitely split the plastic. Difficulty in stripping of the crown. That is, I'm sure you know that before you do the light curing of the composite, always remove the excess composite from the gingival margins before you light cure it, okay? So that you don't cure the excess margins and then it's difficult to strip the crown from the clinical crown of the tooth. Increase chair time. I told you the trim crown prior to appointment, so it will decrease the chair side time for trimming the crown. See, this is exactly what I was telling you. Pre-appointment prophylaxis is always good. Always do prophylaxis for the first time when you have, when you have decided that you will do a crown, and of course prescribe them chlorhexidine gel. See, sometimes patient cooperation is not there. Excuse me, and you try to do the strip crown without tooth preparation. Look here. The retention is not enough, because on this part where you didn't reduce the clinical crown, it will very hardly any composites there. And secondly, the aesthetics will also be compromised. So it is always better, if you do the reduction of the clinical crowns and then put composite, strip crown, improved qualities of the aesthetics is there. Okay, now I'm sure you have biological restoration, like your polyethylene fibers, grossly. I'm talking about grossly carious primary teeth where you hardly any tooth structures left. Okay, all this I'm sure you must have encountered, or case reports are hundreds of case reports you will see in the literature. Fiberglass posts are there, orthodontic wires in different kind of Greek alphabet, alpha, beta, theta, I don't know what all, like variants of corona these days. All different kind of Greek alphabet shapes have been created to use as intercanal retainers. But mind it, all these are case reports. The longevity of these have not been studied for a long period of time. Okay, so always it looks very nice that okay, you have done it and you have put a composite strip crown, but how long it is going to stay? Okay, always I have also used it myself. This is my case. Okay, when I kept on removing the caries, ultimately I left with these kind of structures. Then I put the fiber post and then put on the zirconia crowns, or for that matter strip crowns. But trust me, it doesn't always work. Out of 4, maybe 1 or 2 might come out over the period of time if your patient is very young. Okay. So yes, one study is there. I have to be honest. It is from Iran. Okay, Memarpour and Shefai in 2011. Published for 3 years. They have followed it with the polyethylene fiber posts and composite strip crowns. Definitely, the retention and aesthetics. 81% retention after 30 months. So it is quite good. If you see 80% is quite good. But again, the longer period of time you follow up your cases, the more you understand whether the aesthetics or retention is not compromised or not. So caution is when the caries is standing below the gingival margin, or when moisture control is not attainable, when minimal enamel remains after caries removal, or child is too young or not cooperative. So please keep in mind, and when you're using resin-based composite materials, or that matter strip crowns, always have a caution, okay, whether it is going to stay for a period of a long time or not. Professor Nandlal, how much time we have? Accordingly, I will,
So I think maybe another 10 minutes should be fine with you.
I can speak for 20 minutes also. It's up to you guys, okay?
Yeah. 10 minutes should be okay. Or maybe another. No, we have kept it open with the discussion till 3:30. So.
Okay, fair enough. When you tell me 5 minutes before it is, I am going more time, please let me know. I will just manage the time.
Sure. Yeah, sure. Please go ahead. Yeah.
Professor Nandlal is enjoying from his car, the lecture. Okay, let's continue. Okay, now in 2018, as I mentioned, that fiberglass reinforced, resin crowns also has come in the market. They are flex fit technology. It gives a very good tight margins. And some of you, if you used the zirconia crowns, you must have realized that zirconia crown is the passive fit. I mean, you prepare the tooth structure according to the crown, correct? So not like a stainless steel crown, right? So, but here it's the flex fit technology, which gives you a very good tight fit margins around the gingival margins. But it is composed of fiber mesh sheets of carbon or quartz within the resins, okay? And it is all white, but only one shade is available. It's metal free, and it's bisphenol free, and it is autoclavable also, because other crowns are not autoclavable, and it requires minimal tooth reduction. In very good friend of mine, Professor Laila from Egypt, Alexandria University, published this, clinical evaluation study in Quintessence journal, okay, in 2020, and she found that after 6 months, crown fractures from chipping to large loss of the structure, it's a significant deterioration in the color. See, because these crowns are made of basically composite. They have added carbon, they have added quartz to give a good, strength to the restoration. But over the period of time, clinically in the mouth, the color as well as the durability is of a question mark. So there was a decline in parental preferences. But of course, there's some advantages as well. It's term of preparation and insertion is much easier, not like in zirconia crowns, and it has got a good margin integrity because it has a very good fit around the margins. Pre-veneer crowns, basically these are metal crowns, and the companies have machine compressed the composite over the label surfaces to give a good aesthetics, but they are very expensive because they're expensive as compared to strip crowns and bulky. Because they have steel crowns, over that they have a composite crowns. So again, you need a good tooth reduction. You can, you can crimp the palatal surfaces, but you can't crimp the label surfaces, okay? And if the modification is required, little bit modification required after inserting or cementing the pre-veneered crowns, then you can't, do that. So it will compromise the aesthetics like this. You can see here, okay, like here. But chipping also is a very common feature here. So there are also a little bit of plaque retentive. Look at this, one of our case. Okay, we put pre-veneer, it's from New Smile company. And after 6 months, you see how much plaque retention is all around on the margins. Another case, look how much puffiness of the gingival margins are there. So biocompatibility again is a question mark. Posterior pre-veneer crowns are also available. They are bulky too, lack natural appearance. Coronal from Ireland, has done extensive work on this type of crowns. In fact, she published one article also in EGPT, if I'm not wrong. And no, it was in Journal of Clinical Pediatric Dentistry. Again, she found out there's a fracture of veneer facing actually more in posterior as compared to interiors because of the vestigative forces. So fractures are mainly occlusal. You can see that here. Monolithic zirconia crowns, I will not go in detail, but only disadvantage is that very limited shades available. Now New Smile is coming with the light and little extra light shades, but still majority of the companies are making one shades only. Excessive sitting pressure may fracture the crown. If you are fitting it and the crown is not fitting on the tooth, you try to push it more, it can fracture. Saliva and hemorrhage also should be controlled because it has to be, cemented with the luting cement. Again, no crimping is required. But of course, it has a good advantages of aesthetics. It is a strong material. It has got good, it's a gingival friendly, less plaque retentive, but tooth reduction is more and expensive and wear rate. Okay. Now, a lot of people say that zirconia crown is a hard structure and we are putting it on the opposing natural primary enamel might, wear. We have done a lot of studies. I will be just quickly going through that. But trust me, the tooth wear rate on the antagonistic tooth is very minimal against the zirconia crown because the masticative forces are not that much like you have in adult dentition. Okay. But just if you need to do some adjustment, then you are removing the polished surface. Then it becomes more rough and then it can cause little bit of tooth wear on the opposing tooth structure. So 20 to 30% more structure is required to reduce as compared to stainless steel crown. So look here, the tooth structure with the same tooth which I tried to put to the stainless steel crown, it fitted, but it was not fitting. I need to reduce it more to fit the tooth number, size number 2 of this new small crown. So more circumferential reduction is required in comparison to stainless steel crown. The zirconia crown needs to have a crest of contour completely removed. In a stainless steel crown, you don't do that. So no ledge should be there in subgingivally. As its thickness is definitely more in compared to zirconia crown. You can see yourself how thick the zirconia crown is in compared to the stainless steel crown. And sometimes if you are contamination is there from the gingival sulcus while doing the tooth preparation, again like a composite strip crowns, the bleeding, the cement, luting cement become dark underneath the zirconia crown, it starts showing. But advantage is that if you do the cementation and later on a little bit of asymmetry is there, you can always reduce the incisal edge under a good copious amount of water. So there is no micro cracks in the zirconia structure, and you can have a very good aesthetic results. Okay, this one this paper has been just recently accepted. You are the first one to I am sharing this findings. Some of the zirconia crowns which we used to place, and the tooth structure was, for example, here you see, it's not that badly broken. We put zirconia crown, but later on, without any history of trauma, we started seeing some of our zirconia crown placed in the anteriors going into infraocclusion. Like if some injury has occurred and it has gone ankylosed, some kind of thing, Again, I checked with a lot of authors, a lot of companies, but still no one was able to tell us what was the reason. And it was not only one teeth, so 7 teeth. In fact, the case report series is going to publish very soon in European Journal of Pediatric Dentistry. This is another case. You see zirconia crown we put here. Actually, the photo is not very great here because this was after GA and the parent sent me this picture. You can see, but you can appreciate the zirconia crown on tooth number, 5-2 has gone intruded. Okay, but the good part is it comes out on its own. Like you have an intrusion, luxation in a primary teeth injury. So you see here, okay, it went again inside, but it came out again. Complete eruption in 2 years' time. But again, what's the reason? Maybe they have injuries which we don't know because parents are not able to tell us. But definitely some kind of infraocclusions we are seeing with the teeth which we push a little bit more gingivally. Maybe they get stuck to the bone. But this is a finding which I would like to share with you. But again, comparison to all the durable, whenever you're selecting any extracorneal restoration, they should be durable, retentive, and aesthetics. That is the most important part which you should keep in mind. Look at this now. This is the zirconia crowns. These are the, stainless steel with the composite facing. Look how much biocompatibility, very clearly the difference, you can appreciate that. So biocompatibility as concerned, zirconia crowns are the best. So we did a randomized control trial comparing 3 aesthetic full coronal restoration in primary incisors with my students. And, we had this kind of you see, this is strip crown, this is the pre-veneered stainless steel crown, and this is the zirconia crowns. And we found that, zirconia crowns and the strip crowns were the highly, retentive, as well as the aesthetics were good as compared to pre-period crowns. So this is the comparative, chart for full coverage restoration in the primary teeth with all the three, type of crowns I have mentioned, with their aesthetics, durability, what time it takes to place, and selection criteria, indications. So it's basically zirconia crown should be placed when you have a multi-surface caries. You need good durability and retention, and most importantly, high aesthetics demand from the parents. When the aesthetics expectation from the parent is very high, of course, you should give the option to the parents about zirconia crowns, but of course, same time, the expense is always there, and then it had to be decided accordingly. We did another study, a split mouth clinical study, evaluating stainless steel crowns on one side of the mouth and the zirconia crowns on the pulp treated primary molars. Like this, you see, all teeth required pulp treatment. So we did a zirconia crown on one side and stainless steel crown on another side. And you see, after 1 year, the gingival health, that was exactly what I was mentioning. What's the difference? The same mouth. See here, look at another case, gingival health, and look at the gingival health in this patient. Very nice contour. Plaque retention. Look, stainless crowns have a tendency to retain some plaque. But here, look here, the zirconia crowns, no plaque. Even the natural dentition has a plaque lingually, but zirconia crown didn't have any plaque. So another case, more obvious. Look how much opposing tooth has a plaque, but the antagonistic zirconia crown treated tooth, no plaque retention. Of course, margin integrity can be an issue here sometimes, especially with the mandibular first molar, because of the curvature. If the reduction is not that properly done, you will see over a period of time the gingival recession here, and you see some of the cases we saw, margin integrity is compromised with the zirconia crowns. And if insufficient tooth structure reduction is there, especially with the ease, when the six erupt, it can interfere the eruption of the eruptive path of the unerupted sixes. So I will be just going through. I will not go in detail about this study. We are just, this study was accepted in Journal of Clinical Pediatric Dentistry and will be becoming the next issue of JOCPD. And here we did, comparative evaluation of different kind of glass ionomer based luting cement that can be used with our posterior primary zirconia crowns. And this is the methodology. We found that the resin-based glass ionomer cements offered a better retention than the conventional glass ionomer cement. So if you're using the zirconia crowns, please use resin-based glass ionomer cement, not the resin-based cements I'm talking about. So glass ionomer cements give better retention than a conventional glass ionomer cements. So we did another study with the zirconia crowns to check the surface roughness. The objective for this study was to see whether, because if the zirconia crown surface roughness is more, then definitely the tooth wear against the opposing antagonistic molars of the primary teeth definitely will be having more tooth wear. So we found that the mechanically polished posterior primary zirconia crowns had smoother surface profile than the combined polished and glazed primary zirconia crowns. Because some of the commercially available zirconia crowns have glazed surfaces. I will not tell the name of that, you have to go and read yourself, but they have glazed surfaces, and we found that with the glazed surfaces of zirconia crown cause more roughness profile as compared to the polished zirconia crowns. So my recommendation for the full coverage crown for teeth with multi-surface caries surfaces. Incisal edge involvement, always go for full coverage crown. Extensive cervical decalcification, always think about zirconia crown, the full coverage crowns. Of course, pulpal therapy needs full coverage crowns. Hypoplastic, enamel affected teeth. The bonding with the tooth color restoration is always questionable. Go for the crowns. And if you are not sure about the moisture or hemorrhage control, again, think about the extracoronal full coverage crowns. And of course, if you have finally last is that if you have more than one surface is involved in caries process, go for full coverage crown. Before I end, I'd like to invite you all, for a conference which is going to be held in Dubai from 3rd to 6th November 2021. That is on molar incisor hypomineralization, investigation and treatment. Please do plan to join. As of now, I hope the corona situation improves and you all are, able to join in physically and person. But in case the situation is like that, then we are, have a plans to hold it, in virtual as well. So hope to see you soon there. And with that, I, stop my presentation. In fact, I would like to say something about this slide. Just remember me, Dr. Nandlal, I always use this slide in majority of my presentation when I try to, cover this kind of, topic. This is all three boys are real brothers and they are all from same family. And it's a very funny thing, and I was presenting this presentation and our dear Professor Chawla was sitting in, so, what I mentioned that this is the eldest boy, this one, his name is, I remember, Abdullah, very sweet family, local Emirati family. And all three, coincidentally, I have treated under general anesthesia, okay? So I have put strip crowns for this Abdullah. This is Abdul Rahman, and I put pre-veneer, new smile crowns for Abdul Rahman, and the Muhammad I put zirconia crowns because that time, I was more versed in availability of zirconia crowns were there, and the father was very happy with, with Muhammad's dentition because I put zirconia. The cosmetic is much better than all other kind of, full coverage crown. So I just, mentioned and I stopped my lecture. Then Professor Chawla commented, Tarun, I'm not happy with you. I said, sir, what happened? He said, Tarun, if the first child came to you, why didn't you give them a very good lecture on prevention? Why other two siblings had to come to you and you have to treat them again for, under general anesthesia for a full mouth, rehabilitation? So it's a really eye opener for me. Prevention is sometimes, we always neglect as a clinician. We always need to keep in mind that apart from the restorative treatment, we should always, keep our focus on the prevention as well. Thank you once again for your patient hearing. Professor Nandlal.
Thank you, sir. That was a wonderful presentation and it was very good and inspiring. There are a couple of questions. The first question is, which type of extracoronal restoration is generally preferred on a hypoplastic tooth?
It's very simple. Good question. I must appreciate that, but very simple for me to answer. That is stainless steel crown. The moment you have any kind of hypoplastic or hypomineralized defect on the tooth molar, or that for that matter, we're talking about posterior teeth. Definitely go for stainless steel crown because all the other kind of crowns are somehow depending upon some kind of bonding. So it is better to have a stainless steel crown as an extracoronal restoration whenever you have any defective enamel defect is there.
Thank you, sir. Another one is, can crowns be given on teeth which have anomalies like gemination or taurodontism?
Okay, see, now there are two things I think Dr. Arun Dati has asked, right? That is gemination and taurodontism. Taurodontism is basically like it's a bull tooth, we say. It's a huge, already you have a huge canals, pulp chamber in the crown is bigger than the roots. So, okay. So what I feel that if pulp involvement is there, then you have to treat it like any other kind of a tooth. No much difference is there. But coming to gemination, the gemination, you always have to keep in mind, like if you are going to do as a prophylactic measure, that if you it doesn't get a pulpally involved, later on, then make sure, only my advice is that make sure the tooth is clean, the pulp inflammation is not there, and you can put it like a normal crown. There's not much difference in there. But gemination, I have not seen, to be honest, much. Maybe literature is there in the posterior teeth, and gemination is more common in anterior segments where you don't need this kind of crown. Yes, mandibular gemination is very common. You can do that with the strip crown is there, interior zirconia crowns are there. You can do, even the Figaro crowns are available, but make sure pulp involvement is not there.
Thank you, sir. Another question is, what is the choice of crowns in case of a ECC? I'm sure you've already answered it, but...
Of course, see, again, depend upon, doesn't make a difference if you think that expectation is higher from the parents and you have a good, parent can afford the expense of the cost factor of the zirconia, you can put zirconia. But again, because if you, I'm presuming that ECC, you have multiple, posterior teeth are involved in that. Then again, to place the two, it needs expertise. To place a two zirconia crown adjacent to each other, like for that matter, if you put a two adjacent stainless steel crown, also sometimes it takes time to get training. As a resident, you find it difficult, but over the period of time, it becomes more easy. But again, depending upon the expectation of the parents, again the answer is the same. But stainless steel crown or zirconia crown doesn't make a difference. But if more caries, go for stainless crown.
And the last question is, can a crown be put on a hypoplastic tooth which is partially erupted?
Partially erupted, now again, it's a little bit, not a well-framed, I'm sorry, Dr. Jessica, it's a well-framed question, but still, I will try to answer it. I hope I am able to, justify your question. See, if you can, if it is partially erupted, it can be 1/3, it can be half, it can be 2/3 of eruption. It depends on, if only a little bit of distal operculum is there, you can easily, put any crown, whatever you want to put. But it is only half, then you have such a good, high viscosity glass ionomer sealants are there. Try to, of course, I understand the question is good, that, you're trying to minimize or prevent the post-eruptive breakdown. But again, depend upon the clinical scenario, But yes, answer is that if you see like this, in a routine clinical examination, any hypomineralized, molars, 6s or E's erupting, and whether it's not fully erupted, but it is having, some kind of enamel defect, always try to, seal it, or restore it. Even, high viscosity Equafort is there, you can put it, and once it fully erupt, then you can take a decision for full coverage.
Thank you, sir.
Yeah, so that was a very good question actually, because many a times they see the hypoplastic teeth and particularly the molar hypoplasia very early in life. That is by 6 years, 7 years we see, and they report. But then up to 9 years, normally we see the root is still developing. Like we also had the controversy about putting orthodontic bands. If you have, of course, we do give a space between around 6s, but then there is some articles where they say you've got to be very careful when you give a band. Does it really interfere with the eruption pattern, or does it create delayed in the completion of the root formation and all those type of things? I think there is need to be still have a strong evidence in the long term, because nobody had so far, except for the statement like orthodontic bands on an immature teeth, does it really interfere with the eruption pattern or formation of the root? So similarly, I think whereas the stainless steel preformed crowns used to be 6s is quite different, but when we go for, if we are putting a temporary like preformed stainless steel crowns, I think Dr. Tarun would agree to me that it should be fine. But when it comes to zirconia crowns or permanent restoration, I think we need to wait up to 9.
I agree, completely agree with you, Professor Namlan. That's the reason you will see the posterior zirconia crown for permanent teeth are not that successful. It needs massive tooth reduction unnecessarily, and it is which can be easily managed by the stainless steel crown. And if the patient wants later on to put any aesthetic tooth color restoration later on after the age of 18, they can do it. But once you cut the tooth unnecessarily, already the structure is compromised. I totally agree with you.
I think one more interesting thing was that the listing of new additions which you had made. It was very interesting to know altogether the indications where the other multiple surface caries has been added up, and that has been one of the challenges which even in the restoration which you covered up, it was very nice that you should not do only a partial restoration whenever it is more than half of the crown surface is decayed or needs a restoration. It needs to have a labial veneer kind of effect, which also I had worked on about whenever there's a two proximal lesions, large lesions, it needs a labial veneer coverage. That was a very, I think we are in the same lines which you told. So never do a intracoronal filling or the crown built-up or a restoration partially, which should look nice, but besides aesthetic, we always see a failure. We had done some work, but it's still not, we have not yet published. When we do two independent proximal restorations or two proximal restorations with the labially veneered surface, that would be odd. I mean, of course, full crowns is always there, but if a person is opting for a restorative way of doing the two proximal lesion, it's better to cover the labial surface as well as like we do veneer. Yeah,
Agree.
I think yeah. So I thank on behalf of JSS Academy. I'm sure Dr. Chanchana would like to, as a moderator, she would take over to give a conclusive remarks. Dr. Chanchana.
Indeed, yes, sir. A warm welcome to you, Dr. Karan. Indeed, a very insightful presentation, I must say, especially for the postgraduates who have just started doing their clinical work. It's an insight wherein you are teaching them that every simple work that is done needs a follow-up, needs an evidence-based result. Only then we can very confidently say that what works best. And during their course of those 3 years, if they start from the first year, I'm sure they can generate many more papers by the end of their curriculum. That is very well put across with your publications, sir, and along with your presentation. Very, very well presented, sir. Thank you. Thank you so much.
Thank you, Dr. Chanchula.
Thank you, ma'am. I would kindly request Dr. Seema to deliver the vote of thanks.
Thank you, Dr. Inchia. It was a great learning experience this afternoon. Through this, with the vast exchange of knowledge, there was loads of knowledge coming our way through the international webinar, which was organized on extracoronal full coverage restorations in primary team with Dr. Tarun Walia, sir, as the resource faculty. There have been many undergraduate students, postgraduate students, and faculty members who have benefited today from this webinar. On the behalf of the organizing committee and on the behalf of the Department of Pediatric and Preventive Dentistry, I, Dr. Seema Deshmukh, would like to sincerely extend my gratitude to Dr. Tarun Walia, sir, for enlightening us with his immense knowledge on extracoronal full coverage restoration in primary team. I'm sure all the doubts that were present, all the inhibitions that everybody had have been clarified now, and all of us are motivated to provide the best to our pediatric patients. Thanks a lot, sir, for your time, for your patience, and for sharing your vast experiences with us. Sir, Sumukh, kindly share the certificate. I request Dr. Tarun Walia, sir, to kindly accept this certificate of appreciation on the behalf of the organizing committee.
Thank you very much.
Thank you. Thank you, Dr. Arun. Actually, if you were here in person, we would have had a different type of an appreciation. So hope we see you sometime.
This is a new norm, you know. This is a new norm now, Mr. Nandlal. We should start accepting it now. Now, even my students know. Next year, we are starting our semester in a month's time. So I was talking to them with the timetable. Listen, no, whether Corona is there or not there, all our lectures will be online now. They have got it's a new norm. Period.
True. Even we are continuing the same way. All our seminars, though they are physically here, we are still continuing. So it is like actually a very good way of keeping documentation and exchange.
I agree.
Seema, please take over.
Thank you very much to all, Dr. Chanchula, Dr. Seema, Dr. Inchia. You have got an excellent team, Professor Nandlal, and thanks once again for giving me an opportunity to share my area of interest with you all. I hope it was of benefit. Thank you.
Sir, I would also like to thank the JSS Academy of Higher Education and Research, our principal, Dr. Ravindra S. from JSS Dental College, for helping us to materializing this webinar. My sincere thanks to our head of the department, Dr. Nandlal sir, for constantly motivating us to strive towards excellence, to strive towards upgradation of knowledge, because of which we could materialize this webinar today. Thank you, sir. A sincere thanks to the organizing committee and the faculty of Department of Pediatric and Preventive Dentistry for their constant support. I would also like to thank the technical team for helping us to connect virtually on this platform. A special mention to Dr. Sumukh. And last but not the least, I would like to thank all the participants for enthusiastically participating in this, for helping us to make this program a grand success. I would like to thank all once again and wish everybody a great day. Thank you.
Thank you once again. Pleasure was ours also. Thank you. Thank you. Take care. Stay safe, everyone. Stay healthy. Bye-bye.
Thank you, Dr. Seema. Thank you, Chanchana. Thank you.
Thank you, sir. Thank you so much.